contrast to my fellow panelists, I'm representing a variety of organizations and a long history of trying to provide access to home visiting for expectant and new parents. And new in the sense of first-time parents, but new in the sense of a new baby in the home. So we are uniquely positioned in Minnesota in that every single county in the state has a public health department that has some form of home visiting available. But home visiting is a tool that's used by many different kinds of programs, including Early Head Start for their home-based program, including programs that are designed to intervene for families where there's risk of child abuse or has been abuse and neglect, including families where there's some other need for a therapeutic intervention. So think about home visiting as a tool, and then you have to back up and say, well, why home visiting in early childhood? And how is it different in the early childhood realm? And how do we build on the fact that we have some capacity in every single county, and we have evidence in every county that home visiting can make a difference in families? So let's start with the fact that from the public health perspective, home visiting was seen as a developmental process for new mothers, part of maternal and child health. But now we can apply what we've learned from brain development, and we can apply what we've learned from adverse childhood experiences study to that baseline of healthy development for children. So we know that brains develop in a lightning fast mode prenatally till about 3. It's not that they don't continue to develop, but most brain development for children is done in that period. And that becomes a very critical period for what happens. The brain develops based on the relationship with the caregiver, the parents and the other caregivers, and what's going on in the child's environment. So if we have families, 42% of all births in Minnesota are to women who are medical assistants. In this county, it's over 50%. In many counties, it's over 50%. And we know that that means those families are in high levels of poverty. They're not within the 200%. They're below the federal poverty level. What does it mean to live in poverty in today's society? Well, I personally have not experienced that. I've been poor, but I've never been in poverty. And we do know that it means that there's a lot of challenges and stressors on that family, no matter how willing, how loving, how dedicated the parents. If you're spending 30% of your income on childcare, if you're spending 50% on housing, which is what those families face, then you're, just the financial stress. Plus, we know that a lot of times there's a single parent rather than 2 parents available for the child in those families. And then there can be, I think I read recently that 6,000 children who are homeless are under the age of 5 in our state. That's, I think, another wilder study that was done. So if you don't have a permanent home, if you don't have a reliable income, if you have a lot of instability in your family, it stresses the family. It stresses the child, it stresses the caregiver, and that affects the quality of the relationship, and it affects the way the brain gets wired. And so we have a real choice, a public policy choice in our state, that we can really work to make sure that those early years are connected into systems that help the parent do the best they can and help the relationships be nurturing so that the brain is wired in a way that gives a strong foundation for future health, for future learning, and for future success in life overall. But we haven't we've considered that we thought it's nice to do, but not essential to do, home visiting. So if you look at Richard's statistic of 0 to 2, there's not a lot of service for children, and what there is home visiting, and we know that home visiting is underfunded. We have evidence of which programs really work the best. We have a variety of 9 national models. We have probably 60 models in operation in Minnesota through public health alone. So we can do some things where we move to what's to be shown as effective. But we also have to ask the question of how do we have access? And the access question becomes one, the term you just used, Angelique, is one I'm not familiar with, but it captures the idea. It's sort of like culturally relevant, culturally competent. What was the word you used?
Culturally responsive.
Culturally responsive. I'm going to learn that because that really does describe what we need to do. It's very hard to engage families under stress. It's hard to keep them coming to programs. It's hard to keep them engaged. And do the people who are the navigators as home visitors, are they culturally responsive? And can we engage families in a way that's meaningful to them? That's some of the challenges we're facing. The funding for home visiting in Minnesota, we have $8 million of TANF set-aside money. That money, that's not a secure source of funding. Plus, we have county funding from county departments of health around the state. We have philanthropy. And nurse-based programs can bill under medical assistance to those that are eligible. There is not a stable source of funding for home visiting. So even though we have another $8 million that's going to come into our state that has to be spent kind of quickly now with the new federal Affordable Health Care Act, that's a 3-year grant, just like Race to the Top and some other things. And can we really gear up if we're only using 2 models of home visiting to spend that $8 million? Can we really gear up? Because some of the models require the use of a nurse, which is great, but there's a nursing shortage for doing some of those projects around the state. And are we going to have to be using only one of those 8 models when we have over 60 in use in our state? So how do we start to measure the effectiveness? Those are the kinds of things we're facing as a state. How are we going to fund it? Are we going to overcome the resistance for voluntary home visiting? Do we have the cultural responsive programs that really can engage families? And do we have the way to carry them through till the child is 3, knowing that families under stress have different developmental outcomes. You can detect it as early as 9 months or 18 months of whether or not the child's developmentally on track. And shouldn't we be making that investment when we also have very clear evidence, very, very clear evidence, and a reduction, not only better outcomes for children, but reduction in social costs for language remediation, the higher incomes for families, less spending for public programs over time for the families that are successfully engaged in effective home visiting programs. It's a smart investment. We're choosing not to make it. We don't have a very stable source of funding.